analysis. My name is Maria Bunos, and I am the practice lead for coding and reimbursement tools. And joining me from Wolters Kluwer are Lee McMillan, Senior Product Marketing Manager, and Ray-Ellen Kishbaugh, who will be presenting today, and she is the Manager for Customer Success and Product Development. We will be taking questions throughout today's presentation. All lines have been placed on mute, and all answers to the questions will be addressed at the end of today's presentation. And without further ado, I will turn it over to Ray-Ellen Kishbaugh. Ray-Ellen?
Thanks, Maria. Welcome to the call. We only have a half an hour today, so I'm just going to go right ahead and dive right in. Compounded by changes from the Affordable Care Act and the implementation of ICD-10, the already complicated inpatient prospective payment system has left our clients, which include providers, payers, consultants, and even regulators, struggling to keep up with the complexity of both the MS-DRG grouping and the payment system. The payment has become much more complicated. The regulations are confusing, and the pricer tools that the government publishes are quite cumbersome to use. So Wolters Kluwer and New Health Analytics have partnered to create a series of tools that demystify IPPS payment, and they allow you to instantly compare your Medicare expected payment to other providers, benchmark against regional, state, and national averages, and even batch group claims in either ICD-9 or ICD-10. So today what we're going to do is take a deep dive into some of the new changes that have occurred as a result of the Affordable Care Act, and we'll be using screenshots from the DRG tools as a way of making those changes a little bit more concrete. At the end, I will actually do a product demo. We've done 3 of these seminars so far, and we have recordings, and if you want one that's really focused just in on the tool, you can watch one of those recordings. Today is going to be a little bit more educational. And also I'll add that we're so happy to set up a custom demonstration for you if you see something here that you want to drill down a little bit deeper into. So just as a little bit of background, I want to remind you that the inpatient prospective payment system works through an MS-DRG grouping system and a per stay rate that gets paid by Medicare. In theory, this is a fairly simple system where we take patient information and load that into a grouper, and then we get a prospective payment system for that stay. In reality, the coding and grouping logic has become quite complex, and the payment made to each hospital is provider-specific and adjusted based on a number of factors, including location, beds, patient makeup, quality reporting, and a lot of new performance measures. So what we notice is that healthcare professionals need a really simple way to understand the proper coding and reimbursement under this new system. And so our online grouping, payment, and analysis tools are there to help make it easier for you to audit and predict IPPS payment and in real time understand errors and claims issues that you might have. So in this discussion, I'm going to focus on the changes, but I just want to give you a tiny little visual review. If you're new to IPPS and you want to go back to the beginning, I'd highly recommend that you read the MedPAC Payment Basics and the CMS Acute Care Inpatient PPS fact sheets. Those have links at the bottom of this slide, and they'll bring you up to speed quite quickly. But essentially, I'll just start our conversation today by saying that the Medicare expected payment system is now based on a series of complex calculations that you can see there on the left. The payment is a combination of operating and capital portions, but also now with ACA, there are low-volume add-ons, there's a pass-through add-on, and a number of other adjustments based on quality reporting that our tools will help you to visualize so that you can understand how things have shifted. Traditionally, organizations would know their base rate, and they could use the Table 5 that's published in the IPPS final rule as a back-of-the-envelope estimate to see what their expected MS-DRG payment might be. That was never accurate if an outlier payment adjustment would apply or if there was a per diem pass-through add-on, and that calculation and that estimate has become even more inaccurate for organizations that are qualified for uncompensated care add-on payments and for SCH and MDH hospitals. To kind of make that concrete, I used our tool to take a look at a specific DRG. I just picked 267, and a real-life hospital in Alabama for whom I had their reported or their internally used base rate. So calculating the base rate times the relative weight of the DRG gets me to a $52,000 payment for this stay. And then when I use the calculator, which is based on data coming from the CMS PC pricer, the actual Medicare expected payment for that stay is only $43,000, which is a significant reduction in payment and 21% off from the estimate. I'll show you the screens when we do the demonstration, but on the left you can see how we break that payment down to show you the portions that are attributable to the capital operating pass-through, low volume, value-based purchasing, readmissions, and hack adjustments. We'll talk about some of those in the rest of the call. So for most organizations, particularly healthcare providers, acute care hospitals, there is a grouper that is part of your coding and claim systems. But sometimes it's helpful to have a standalone tool outside of the payment system, which will allow you to run what-if scenarios and calculate what would happen if you coded this a little bit differently, and to check for common Medicare code edits. So our standalone grouper and pricer is an essential tool for folks who want to do that, but it's also essential for folks like consultants, medical product manufacturers, and auditors who need to understand IPPS outside of the context of their built-in grouping and coding systems. So here's just an example of a real case that I was able to group, just taking a clinical scenario of a 65-year-old male who's been hospitalized for an atrioventricular block and has had surgery while he's in the hospital to insert a dual-chamber pacemaker. So the grouper allows me to simply enter basic demographic information and the admitting and principal diagnosis, which was 426.0, and the surgical procedures, which were 37.73 and 37.83. Our grouper takes two steps in one. It groups and assigns the patient to 244 as the DRG, and then it also calculates the Medicare expected payment. In this screenshot, I use the national unadjusted, and so that comes to about $12,600. But I can show you how this would come out a little bit differently if I look provider specific. So we have $12,658 as the national unadjusted rate, but the actual payment between providers can be quite varied. So I used our MS-DRG analyzer to calculate reimbursement for DRG 244 using that national base. And then for curiosity, I thought it would be interesting to see the state average in all the facilities in Massachusetts. There are 62 of them. So the Massachusetts average is $17,000. That's much more than the base. And then taking a look at one of the highest and lowest paid providers in the state for this time period, we can see that the payment can be significantly different, ranging from $15,000 to $26,000. In this case, the big payment adjustment for Boston Medical is that their operating payment is much higher due to their DISH and their IME adjustments. But I also want to draw your attention to another difference between these two hospitals, which many people refer to as the market basket rate. So notice the orange info buttons at the top of each column. These designate an assumption that's made regarding the yearly update. Boston Medical Center is receiving the full 2.2% market basket update. The Soldiers Home is only getting the 1.475% update, and that's going to account for some of the reason why their operating portion is a little bit lower. So I thought this might be interesting to drill down a little deeper into. And I can go into the DRG analyzer and do a what-if analysis if they had received the full update. So in general, that market basket update is just one of the changes that we're seeing under legislation and regulations like the Affordable Care Act. So hospitals are now expected to engage in a number of activities that are designed to measure and compensate or penalize them for performance. These are buzzwords that you might have heard: quality reporting and meaningful use of your electronic health record. Those two are taken together to determine the market basket update. You may have also heard about value-based purchasing, low volume adjustments, hospital-acquired conditions, readmissions penalties, acute care transfers, and some other buzzwords that are really hot in the industry right now. And essentially, we're hearing from customers that with all of these changes, we really need an easy way to understand Medicare expected payment, and that blended rate formula that we used to use is really just not cutting it anymore. Let's talk about that market basket payment impact. This is, it's a fascinating way that Medicare has figured out a way to incorporate this as a change in everyone's calculation. So one of the features of, one of the features of the, oops, I'm on my wrong slide, excuse me for a second. So what happens is if a hospital has submitted its quality data and is a meaningful user of the electronic health record, then they will get the full payment adjustment of 2.2%. And that is published in a little table in the final rule as the operating standard labor share and the operating standard non-labor share. An organization that has not done either of those two things is going to get a much smaller update. And so let's drill down and see a concrete example of that. So in the analyzer, I have the opportunity to create some, ask some what-if questions. So in that hospital in our previous example, they only got the 1.47% update. So that means that their two labor shares are about $10 each lower. And when I put those into the analyzer by just simply changing the values that are shown on screen, I can see that the payment impact for one specific DRG, just run as an example, is about a $102 difference. Now that may sound really small, but if you multiply that out against all the cases that this provider is going to see for a year, we can see that getting more than a 0.5% haircut on the operating payment is going to add up to substantial dollars. Often seeing something like this calculated out concretely might provide incentives for an organization to get into alignment and justify the return on investment of meeting their meaningful use and quality reporting requirements that might have seemed like a nice-to-have feature in the past. Another feature that's been added to the MS-DRG calculation logic is something that everyone is referring to as value-based purchasing. This program was implemented in 2013. It essentially takes a pool of dollars and redistributes them to hospitals based on their overall performance on a set of quality measures. Now this is really important. The market basket change simply talks about whether or not you're submitting your quality reporting data. The VBP is going to reward or penalize you based on that performance in that reporting. So the size of the purchasing redistribution will increase each year until 2017 until it accounts for 2% change. And it's based at this time on a breakdown of how you're performing on clinical process of care, patient experience of care, outcome, and efficiency. Now an important thing to note about VBP is that you're benchmarked against the rest of the country on this. So even if your individual organization improves its quality performance in these areas, you have to keep an eye on what everybody else is doing because you're still, if everyone else improves more than you, you'll be at a loss. So again, our tools are going to allow us to consider how the value-based purchasing adjustment is concretely impacting our reimbursement. So here you see a very fuzzy screenshot where I took a low relative weight and a high relative weight MS-DRGs just so that I could see what the calculated value-based portion would be. And in the low relative weight DRG, it was a $17 payment increase, small amount. But with a higher relative weight DRG1 for heart transplant, which has a relative weight of 25, the reimbursement impact was quite high, $2,500. And again, when you calculate that out, that 1% change across all of the DRG discharges of the year, it can be a significant payment increase or decrease for you. So here's another adjustment that CMS has implemented in ACA. This is not a penalty. This is a gift to hospitals that have a low number of Medicare discharges and have certain geographic requirements. So if you qualify for a low volume add-on, it is going to simply be tacked on to your operating payment, and you'll get an increase in payment. And just for my own benefit, I wanted to see a couple of examples. So for a specific DRG, I looked up a Nevada rural hospital and a Texas county hospital for DRG 865, and I could see the low volume add-on portion was quite a significant addition to the DRG payment. Another penalty that you've heard of is the hospital readmissions penalty. This is being exacted onto acute care hospitals who have a high rate of readmissions. CMS has estimated that a potentially avoidable hospital readmissions account for, get this number, $12 to $17 billion annually. Then to combat that, CMS is introducing and sequentially expanding the readmissions penalty, which affects the operating portion of the DRG payment. Now, even though the readmissions quality reporting measures focus on cardiac, pulmonary, and operating readmissions, the penalty to the hospital is for all cases. MedPAC has estimated that just in 2015 alone, by implementing this change, Medicare is going to save $428 million. And they found one single hospital being close to $13 million of that savings. You don't want to be that hospital. So understanding and getting buy-in from your organization about making the clinical operations changes necessary to reduce hospital readmissions should be a priority. And again, we might want to use a tool to be concrete about what that is. Now, Medicare has published droves of information about the readmissions penalty, but really as a provider, all I need to know is how am I financially impacted by this issue. So to illustrate it, I used some of the data from CMS and enhanced it by running a calculation for a series of providers on a specific DRG that I just chose to examine 190. Here you can see the relative reductions ranging from $6 to over $100. That's a 3% reduction to their operating payment portion. Again, multiplying that out against all of your DRGs is a really important way to concretely demonstrate that we don't want to be getting that penalty. So shortly I'm going to go into the tools and give you a real live demonstration of those tools. But before I do that, I know that I looked at the folks who signed up for today's session, and we have a good representation of people from across the healthcare industry. So I briefly just want to speak to you about how our IPPS tools can serve you. And then I'm going to show you a couple of screenshots that you can use as a leave behind, and then we'll go into the product. If you have any questions, you might dump them into the questions panel before I get to the product, and I might actually be able to answer your questions by using the tool. So if you're a consulting company that is assisting other providers with their coding, our groupers and calculators will help you to demonstrate the financial impact of the coding reviews and the clinical documentation improvement programs that you're implementing. And our batch grouper is instrumental in letting you recode bunches of claims at the same time. Government auditors are using our tools for exactly that. They're taking a look at claims where upcoding has been done and regrouping hundreds of claims at once to show both the grouping and the payment impact of adjusting those claims in a retrospective fashion. Hospital providers can use our DRG analyzer to look up their expected Medicare payments, including per diem adjustments and outlier adjustments. This is an excellent way to generate a defensible self-payment report that you can use in your managed contracts as well as for self-pay clients, because it is based on the CMS PC Pricer data and the information published in the Federal Register. So it's official government data that you can use as your placeholder for those defensible payments. We have a lot of medical device manufacturers, pharmaceutical and biologics manufacturers as well, that find our IPPS tools helpful to understand the coding, payment, and market trends that are in place for the service lines that they offer. And because you don't need to have this installed in your EHR or pay anyone for a complicated API, it's just a great little web interface where you can generate your own reports and save things for future updates when the quarterly updates occur. Revenue integrity professionals, whether that's on the payer or the provider side, can use our tools as a standalone validation of what outlier payment information is coming out of the system, and also to do those what-if analysis to anticipate future payments. If you know your cost report is about to settle and your variables are going to be shifting up and down, you might want to predetermine what that new DRG rate is going to look like. And then finally, health systems and ACOs can use our analyzer tools to compare and benchmark providers against each other to reveal the ACA impact on how these different organizations are performing and to steer strategy. So the tools that I'm going to be showing you include the MS-DRG calculator, which gives you the opportunity to create the Medicare expected payment with hospital-specific adjustments for all MS-DRGs within the last 5 years. It includes a nice little graph where you can see the history of how your DRG payment has been impacted over time, and it also breaks your payment down into a bunch of different segments so that you can really understand where that logic is coming from. It essentially saves you the trouble of having to download the PC Pricer that CMS publishes, which is a terrible little program made in COBOL that's quite cumbersome on your eyes. The MS-DRG analyzer extends the calculator functionality by giving you the opportunity to do deeper payment analysis, comparisons, and benchmarking. And the batch component in there allows you to batch process over 200 claims at once to validate grouping and payment information. Here's a little picture of that. Now, in addition to these tools, I do also want to let you know that we have the IPPS payment data available to go. So maybe you don't want to log into the MediRegs user interface. What you'd really like to do is create a query that works within your own system. So you can purchase from us the reimbursement rate for all DRGs and all providers going back 20 quarters. And that can be an incredibly helpful way for you to validate payment within your own health systems. That's a lot of solutions. I'm going to let you look at this slide on your own, but you really don't need to, because we'll be happy to set up a conversation with you in which we can understand what your use case is and really recommend the right level of solution for you. You might choose to just subscribe to the analyzer, which comes with the grouper, calculator, batch grouper, and analyzer. You might choose to add that on to your existing MediReg subscription, or you might want to purchase the data packages. We also would be happy to refer you to New Health Analytics, who helped us to create these tools, who can help you with a number of custom data solutions. Maybe you want to translate some ICD-9 claims to ICD-10 to do a financial impact assessment and see where you can expect MS-DRG shifts. We can help you with that, a very affordable solution with excellent reports. Or perhaps you have some custom information that you need to export, and we're happy to work with you to create any kind of custom solution that involves big data. Again, I'll leave you this slide to take a look at on your own. But here are some compelling questions you might ask yourself. And if you're answering yes to any of these, might be a good idea for you to set up a half-an-hour demonstration with us, where we'll be really happy to go slowly through the tools and show you specifically for your organization how you'll find them to be helpful. So I'm going to go into the product now. Just forgive me while I switch screens. Maria, do you have any questions for me just yet?
I don't believe so, but let me do a quick check. None right now.
Okay, great. So if you are already a MediReg subscriber, I know I saw some folks on the phone who are subscribers. I just want you to know that you already have access to a few of our DRG resources. Over on the left-hand side under Lookup and Payment Tools, you'll see the new button next to the MS-DRG grouper and calculator. When you click on that, it's going to take you to a screen that looks like this. And you'll have access. Let me jump up to the screen. Oops, I'm sorry. You'll have access to the green Calculate button and the blue Group button. And then if you upgrade to the analyzer, you will also have access to the batch grouper and the analyzer. If you are a standalone subscriber, you don't need the MediRegs coding suite, but you want just the analyzer, when you log in, you'd see this screen with all access to all 4 tools. I'm going to start with the batch tool just because I think it's an interesting case study. I'm taking a look at the quality reporting measures for the inpatient prospective payment system, which have been traditionally coded in ICD-9, and now, of course, they need to be translated to ICD-10. And I was specifically interested in sepsis. So I went to our ICD-10 Explorer tool, and I searched for the word sepsis, and I searched for the word septicemia, and I created my own ICD-10 code list of all codes that seemed to say sepsis or septicemia to me. And I wanted to see if they all are included in Table 3.2 of the Inpatient Quality Reporting Manual. And what I found was a whole series of codes that weren't. And so these to me seem like sepsis codes that might want to group traditionally the way the ICD-9 codes from Table 3.2 do. but I just wanted to double check and see what the grouping logic is doing. Every time I do one of these investigations, I find the ICD-10 grouping logic to be full of places where I scratch my head in confusion. Now, the IPPS proposed rule was just published, and we have a small comment period in which we can get a hold of CMS and let them know that we think maybe there are some flaws in the grouping logic, which might have come as a result of them using GEMS to translate the I-9 lists and getting those gaps institutionalized. So we want to comment now so that in October we get properly paid as we would expect. And even if we don't have time to comment, we should brace for the impact of the changes that CMS has chosen to make. So just quickly, I downloaded an Excel file that showed me where the columns were, and I just filled that out, playing with all my different diagnosis codes, and then I uploaded it at once. So you can see here in my report the actual admitting diagnosis that I used, and then you can see the DRG that was assigned, 872, which makes sense to me. Severe septicemia or severe sepsis sounds like the right DRG to me, and I can see the DRG payment. I expected almost all the codes would group this way, and that just wasn't the case. Here's a DRG, granted quite a significant diagnosis, anthrax sepsis, that groups to a different DRG. And I think it's fascinating that it is grouping to a with major complications DRG, even though it's the only code on the claim. I didn't know that the grouper could work that way, and that's quite interesting to me. And then I can just scroll down and see some others that show up as sepsis in terms of a synonym match that a doctor might use as a diagnostic term that might group to higher or lower DRGs, and really just evidence of places where we want to be quite clear. I'll be happy to share this report with you if you'd like to get in contact with me after the call. So now let's go into the analyzer. Maria, can you just remind me of how much time we have? Because my little
minutes.
Awesome, great. So here's the analyzer, and I'll just do one or two quick examples in here. I'll just pick a provider, and you've got a great little search tool here, and I'll enter one of my DRGs, and I'll choose today as the discharge date. I'm going to leave the length of stay blank for now, as well as these other items, and just run the calculation and show you what the results look like. So this medical center is getting the full market basket update, and I can click and see more information about this provider if I'd like. I also noticed this little top CMS button. This is going to create a nice little graph for me that shows me how this provider has gotten paid over the past few years for this top 100 DRG. And for some reason, this particular organization doesn't have data for 2012 and 13, but that should show up for other providers. Then we see our Medicare expected base payment rate and all the breakdown. And then we come into the special analyses section. We didn't put any charges in, so the outlier calculation is not occurring. We also didn't put in a multiplier, so that's not occurring. And then we're seeing the per diem analysis. I had a GMLOS of 1 entered. I had an LOS of 1, and so that's telling me that the per day cost is about $11,000 or payment. But the actual geometric mean length of stay for this reported in Table 5 is 3 days, and so the length of stay, the per diem rate would be that. Down here we see the variables. Here's a very quick snapshot of the up and down of all those ACA variables. This guy's getting a $62 hit on this day. And then we have all the variables that were used in the calculation. It's here that I can change any variables that I want to perform that what-if analysis. And it's really hard to find from the published information in the CMS data set this information so transparently produced. And then down here you will notice the provider data source and which pricer we've updated to. If you're finding IPPS frustrating, it's because you're paying attention. They're already up to version 4 for this year. And also there are the formulas that we use to perform all the calculations above. So let me just copy that column and do a little compare. What if we did have outlier charges associated with this case? So I'm going to enter that and run and scroll down, and I'll be able to see that this case did qualify for an outlier and what that outlier adjustment is going to be. This prints beautifully as an Excel or a PDF report. I can copy the last column and run another analysis. Maybe I want to compare one provider to another provider. and that's going to be very simple to do. I can also compare state averages to an individual organization. The state one takes just a minute. There are 64 providers in Kentucky. So the Kentucky average is $12,000, and you can see the averages broken down there. I can use this as the base, and then that will give me the opportunity to benchmark everybody else against this so I can see who the winners and the losers are, and so on and so forth. So that's about as much time as I have for my demonstration today. What I'd love to do is schedule a half-an-hour session with anybody on the phone who wants to take a closer look, and we can answer any questions that you have there, provide you with sample exports from the tools, and suggest which level of the subscription would be appropriate for you based on the information needs that you have. Maria, do you want to toss me a couple of questions before we let everybody go?
Yes, I would. So, Ray Ellen, the attendee had said that they absolutely love the upload feature, and what are the limitations on the amount of codes that can be analyzed at once?
That's a great question. So 200 per batch, and if you have a huge analysis that you want to do, then we would just refer you to New Health Analytics, which would be happy to give you a custom quote for that kind of work. But just doing it on your own, you can put 200 lines in the Excel file. Frankly, you don't want more than that because your eyes start to get buggy and the screen would take too long to load. I've had a couple places where I did about 500 rows, and what I did was I just broke it up into 3 files.
Great, thanks, Ray Ellen. In the data entry panel for the analyzer, and you're doing your comparison in the columns for benchmarking and so forth, so what's the limitation there? How many can they compare at once?
It goes to 7 columns, and we just stop it there because you start to run out of screen space and the information just gets a little too squishy. But one of the things that you can do is save things in here. So, like, for instance, I've run reports where I'm looking at 7 states at once, and that's kind of cool, and then I saved it. So 7 for now. And then when you have the analyzer, you also can, once you enter your provider information, export a report that has the entire fee schedule for that provider. So DRG 1, 2, 3, 4, 5, all of them in one Excel file.
That's fantastic. Thanks, Ray Ellen. That is all the questions. I'll just give it a couple of seconds here. There's a lot of folks still on the call. Feel free to put in a question if you have one. Let me just check real quick one more time, see if anybody has any questions.
All right, well, thank you very much. The handouts for today are in the chat box if you want to see some of these screenshots. And again, I just really want to underscore, it's great to have a conversation with you about this. So the account manager in your area might follow up with a little thank you for attending. And if you want to get a demonstration, we're happy to set that up.
Great. Thanks, Ray Ellen. That's all the questions for today. I want to thank everyone for attending Increased Claims Accuracy with MS-DRG Analysis. We wish you all a pleasant day, and we look forward to working with you. Thank you.